Now, I do have a website, and I'm glad to say that I have completed 25 years of uninterrupted education of capnography. And actually, this month marks the 25th year when I started this in 1998. It is a very comprehensive website. It has about 360 pages. Now, as you know, that capnography we monitor, usually at the mouth, between two anesthesia circuits, which is the patient circuit and the other one is the anesthesia circuit, our machines and circuits. Now, a derangement of any of these factors is reflected in capnography. But to diagnose the precise problem, you need to understand the physics and the physiology of capnography. That is the problem here. Because pulse ox is the direct monitor. It tells you the patient is hypoxic or not hypoxic. Capnography tells you that something is going wrong here and you need some knowledge to figure out what is wrong to fix the issue before it leads to a catastrophic outcome. Now, just a little bit of a physics, you have to understand that CO2 is a polyatomic gas and it absorbs infrared light at 4.3 millimicrons. So we use infrared technology to measure CO2 in our clinical practice. Now, the water vapor, H2O and nitrous oxide are also polyatomic. So they also absorb infrared light, but at a slightly different frequency. However, most of the current monitors do apply some sort of a correction for the presence of nitrous oxide and water vapor. There are two sensors in clinical practice, the mainstream sensor where the CO2 is measured across the airway, and then there is a side stream sensor where the gas sample is aspirated by a pump into the monitor and where it is measured. Usually the side stream capnography is more useful in clinical practice because you can also, endotracheal tube is not needed for these for monitoring CO2 in a non-intubated patients. Now, this is the classic standard terminology of capnography now. We formulated this terminology in mid-90s, and it is also used in Nunn's textbook of physiology and also the Miller's textbook of anesthesia. It is usually divided into three phases, the phase 1, phase 2, phase 3, and phase 0. Phase 1 is actually the mixture of the gases from the dead space with the alveolar gases. Phase 3 is actually your alveolar gases. So phase 1 is from the dead space, phase 2 is a mixing of the two, alveolar dead space with the dead space, and phase 3 reflects the alveolar gases. And then you take the next breath. This is the classic time capnogram where the CO2 is plotted against time. Now, this is the basic physiology and everyone must have some understanding of this. As we know that the lungs have got some sort of a ventilation perfusion mismatch when you move from top to bottom. At the bottom of the lung, the lung has more perfusion compared to ventilation. So the CO2 concentration at the bottom of the lung is more. And they also have long time constants. So when this is plotted into a capnograph, you get a rising alveolar plateau as you can see. That rising alveolar plateau is not a line. It actually tells you the ventilation perfusion mismatch of the lung of a given patient. Now, the height of that CO2 plateau or the alveolar plateau is dependent on the cardiac output because it is V and Q. So, the shape of the capnogram is reflected by the cardiac output, the CO2 production, airway resistance, and functional residual capacity. You all know about a sloping phase 2, phase 3 in a classic asthma cases or COPD, and you give them bronchodilators and they revert back to normal. So, as soon as you put an endotracheal tube, if you see phase 2 and phase 3 are prolonged, you know that you have actually created some bronchospasm or airway resistance within the patient and that requires treatment. Now, there is a relationship between end-tidal CO2 and cardiac output, which is pretty much actually linear. And these studies were done way back about 30 years ago. Now, this is just an animation reflection that tells you whenever the cardiac output decreases or increases, the CO2 changes. Usually, if the cardiac output is about 5 liters, it's about 36, 32, and 20 actually corresponds to 2 liters. And remember this figure, and I'll talk about it a little later during CPR. Now, how I use CO2 monitoring in the operating room? If the end-tidal CO2 and the blood pressure are normal, we are going to have a very smooth flight in our patient's anesthesia. However, if the end-tidal CO2 is normal and the blood pressure is low, what does it tell here? Perfusion is still maintained very well. That means the cardiac output of the patient is pretty good. So if you give vasopressors, you can normalize the blood pressure, but there is no problem with the perfusion. Now this is a problem area. End-tidal is low and the blood pressure is low, and this, if you do not take care in the operating room, you will have a catastrophic outcome. So whenever I am called into an operating room for an emergency, I first look at the CO2 form. I don't even look at the pulse ox. I look at the CO2 waveform. If the CO2 waveform is good, I know that patient has very good perfusion for now, so let's figure out the problem. If the CO2 is low, I know that we are going to go for impending cardiac arrest in this patient if we don't intervene right away. Now, you can get information from the numbers, just the end-tidal CO2 numbers, high or low, or the shape of the capnography, which is actually very pathognomic of certain conditions, or the difference between the arterial to end-tidal CO2 difference, which is a reflection of the alveolar dead space, which I will talk shortly. This is the shapes, and actually I published in the journal Anesthesiology about all these shapes. You can see they're all available on the website actually. Now, when a CO2 is plotted against volume, that means one tidal volume, you can have the components of the tidal volume, namely the anatomical dead space, the physiological dead space, and the components like the alveolar dead space. The end-tidal CO2, the arterial CO2 difference actually indicates the alveolar dead space. And this is the classic feature which is very useful in our ICU management. If the arterial to end-tidal CO2 difference stabilizes during the course of the ICU stay, you know that the patient is actually doing better and our therapy is working. If it is not, that means our therapy is not working in that patient. Pediatric capnograms, you can get several shapes that are normal in a pediatric patient. The reason is the response time of the capnograph is not that fast enough to match the high respiratory rate and low tidal volume in small babies. However, the newer capnographs are relatively have a very short response time. Therefore, they give a capnogram that is almost like an adult capnogram. Now, what happens in sedation? You are putting an oxygen mask. Everyone asks me, what is the normal CO2? It doesn't matter. Your shape of the CO2 will be slightly different here because of the dilution by the oxygen. So what you do under those conditions, you take that as the normal value before sedation. And what is important is the change from that status after giving sedation will tells you that this patient is either hyperventilating or is going to go to airway obstruction. And I put an algorithm of how to use capnography during sedation on the website. You can see under sedation part of the website. Now, what happens to the decreased cardiac output? I have already told you. Say, suppose your normal end-tidal is 37, and suddenly they lose a liter or 1.5 liters of blood from the abdomen, and your end-tidal CO2 goes. So you know that for a given ventilation, if the end-tidal CO2 goes down, that means it indicates that the cardiac output is decreasing. You better watch out what is the reason for it. Is the patient bleeding? And if the patient continues to bleed, if you don't intervene, the patient goes to cardiac arrest, you resuscitate, and your end-tidal CO2 comes out. Now, capnography is an excellent rescue device for CPR. And it actually, that's why I put this cartoon, it actually can pull the patient out of the death valley. Now, it is the most reliable method to confirm the placement of endotracheal tube in the trachea, even during CPR. In fact, this has been told many times. Even the coroner in England has asked to be told to all societies because he has seen the endotracheal tube during postmortem in the esophagus. That's because the capnography was not used. If you use capnography, you will see those blips during your CPR. And you can actually make a good CPR just by looking at the end-tidal CO2. As long as the end-tidal CO2 is over 20 millimeters, that means you are generating a cardiac output of 2 liters. which is pretty good during CPR. If you are not generating a cardiac output of 2 liters or 20 millimeters of end-tidal CO2, as a team leader of the ACLS, you can actually have the operator change and some other person perform the CPR. If the end-tidal CO2 is consistently below 10 millimeters with a good CPR, that means the prognosis of the patient is bad. Now you know that ACLS more or less mandates the use of capnography during CPR. And this is the basis of the relationship between the cardiac output and end-tidal CO2 I'm pointing out once again. Now, during CPR, when you suddenly see an increase in end-tidal CO2, what does it indicate? It tells us that the patient spontaneously, the heart has started, and therefore it is contributing to increase in cardiac output. So just by looking at the CO2 monitor, you can say if spontaneously the heart has started or not during CPR. That is the reason why way back in early 2000s, I actually put capnograph on our video stands, and this video stand actually goes to all codes in the hospital. So we not only carry a video laryngoscope with us, but we also have an end-tidal carbon dioxide monitor, waveform capnography that is attached to the stand so that we can instantly use and confirm the location of the endotracheal tube. Now, what happens to the air embolism? Very important for the neuroanesthesiologist. It's a normal end-tidal CO2, and suddenly the air gets sucked in from the skull or the brain, and then the output decreases, the end-tidal CO2 decreases, and this actually is a forerunner to think that could this patient have air embolism or not. And this is about thromboembolism. In fact, this is a very interesting case. I gave a lecture to our CA1 class, and next day the CA1 resident was actually doing a hip surgery in a 70-year-old or 75-year-old gentleman. They positioned the patient, and the end-tidal CO2 actually dramatically fell down. Initially, they thought it was induction. They gave a little bit of drugs. Then a thought went to the resident's mind, maybe it could be a pulmonary embolism. And this is where, as the previous speaker said, the end-tidal CO2 fell down. They put a probe, and the patient has pulmonary embolism. So instead of having hip surgery, the patient had a sternotomy and actually the removal of the embolus, and subsequent surgery was done 3 weeks or 4 weeks later. So what I'm trying to say is end-tidal CO2 is a very powerful tool. It gives us so much of information just by looking at the CO2 waveform and the shape. It is not just the number, and that is the reason I said that as soon as even when you pre-oxygenate the patients, see the end-tidal CO2 shape and make sure you're getting a good CO2 shape, then you start your induction, and as long as your shape was prior to before, that means you know that your intubation is fine, you're not induced any vasospasm, and whether your perfusion is good soon after induction. Now, this website, as I said, has got completely, I think I should say more or less everything I have included, because some exam-going students actually asked me some questions, and I put it on the frequently asked questions. And some of the candidates from, say, Australia or England, they write to me in their fellowship, they asked me this question, what is the answer for that? And actually I have put some answers, particularly endobronchial intubation, tension pneumothorax, what happens to the capnography. There is what is called as a capno magic screen under the heading of capnograms. If you put your cursor, whichever capnogram you want, that capnogram actually plays on the TV screen. So if you have some time, you can actually spend some time and look into various aspects of capnogram. But I just gave you some of the highlights of capnography which I use in my clinical practice. Thank you very much.